that we've been involved with for the past few years. The other thing I'll just mention is that I'm involved with a fair amount of research, not just in the type of models I just mentioned, but also in studying new treatments for the behavioral symptoms of dementia, like agitation, anxiety, depression, and also some of the disease-modifying therapies that are being studied through our colleagues in the pharmaceutical and biotech industry to try to bring Alzheimer's dementia one day to an end. So tonight, I was asked to talk about the experience of caregiving for individuals with dementia during COVID-19. And I really want to highlight some of the warning signs for caregivers to watch out for in terms of their own mental health and well-being. Not that it's not always a problem of great importance, but it's really been highlighted and exaggerated during the pandemic of the past nearly 1 year. So I'm going to talk about the impact that we know from the literature, but our own experiences working with families and patients of the pandemic on individuals with dementia, but their caregivers, both in home and in long-term care settings. Talk about some of these warning signs for anxiety, depression, and trauma for you all to pay attention to. I'll briefly talk about a survey we just did on caregivers for individuals with dementia as part of one of our efforts in our system to understand better the scope and the challenges that people are facing. I also want to talk about the concept of resilience in the face of the pandemic that older adults, I think, are demonstrating, which has been one of the silver linings, frankly. And then finally wrap up with some opportunities for both self-care and professional mental health care if needed, if and when needed. So, if you think back over the past year, we've all lived during an unprecedented time. And I think the impact that this pandemic has had on older adults, we know well in terms of their increased risk of mortality, but those with dementia has been especially challenging. And I think it's unfortunately gone under the radar screen in the media, and even general physicians understanding the true risk that people with dementia and their caregivers are facing. But this was an article written last summer, frankly, which really highlighted some of the earliest risks that we were seeing in individuals with dementia, such as the social and behavioral aspects of trying to maintain social distancing and wearing masks and hand washing for somebody who was unable to remember things from moment to moment or had profound executive dysfunction. We've seen constraint in resources from economic fallout, which has been challenging, especially for caregivers during this time. We've seen disruption in usual clinical care pathways, so that especially in the beginning of the pandemic, where all care other than most urgent care was remote, there was lack of access to in-person physical and neurological examination, cognitive testing, and brain imaging. A lot of that now is back online or live, if you will, but now we've developed modifications and we've learned what can be well managed remotely and what has to be done in person. There was also some risk in starting new medications when there was less regular medical follow-up. And a lot of our non-pharmacological approaches for people with agitation and dementia involve being close to someone and sometimes involving touch and regular social engagement. And those opportunities are way more limited. There's been the widely recognized, discussed, and written about problem with social distancing from family members and loved ones and friends, and the challenges that somebody with dementia faces in remote communication because of hearing issues, visual issues, or frankly, the cognitive challenges that they experience. The isolation, although it says on this slide and in this paper, it may be worse in community dwelling individuals and home environments. We know that it's been challenging in long-term care environments where people are often left in their rooms for days and weeks at a time in an effort to keep people safe, but at a risk, potentially a huge risk, of the medical and social and psychological consequences of profound isolation and quarantine. There's well-known and established risks in congregate settings like assisted living and long-term care, and some individuals who really could not be managed in the home environment because of the impact of the pandemic. And this was a study that was published last year, but there was one from last week that I'm going to mention in a minute. But through the end of November, Federal data analyzed by the Alzheimer's Association showed that the number of people with dementia who were dying was 16% higher than the projection for the previous year. And there was over, at that point, 38,000 unexpected deaths that had occurred over the first 11 months of 2020. So essentially, we were seeing more people dying per week from dementia. Nearly 1,000 extra people per week with dementia were dying than in a usual year. And we had started seeing this in the early stages of the pandemic, and most of us figured it was because people with dementia are older, and because many people with dementia were living in congregate settings like long-term care facilities. And what we're starting to learn, based on this data that was just published last week, which many of you may have seen, this is highlighted in the New York Times, but this was an article that was published last week by Wang and colleagues that demonstrated that not only are people with dementia at higher risk of getting COVID, but they're at a greater risk of dying from COVID. And there may be social and biological reasons why. The other very interesting finding in this article was that Black individuals with dementia were at an increased risk over white individuals with dementia from dying from COVID-19. So there are lots of theories about why this is. And by the way, the 6-month mortality and hospitalization risk in COVID-19 in people with dementia were 30% and nearly 60% respectively higher than in those with COVID-19 and without dementia. And there's a lot of theories about this. So people with dementia, we know some of the risk factors with dementia include the metabolic syndrome, so high blood pressure, diabetes, high cholesterol. We all know now that those are risks for developing bad outcomes from COVID-19. We also think there may be a disruption in the barrier between the bloodstream and the brain that allows easier entry of the virus into the brain that can have all sorts of damaging effects on brain function. We've seen very high rates of delirium or confusional states in older people who develop COVID-19. So anyway, there seems to be the bottom line here is that the burden of COVID-19 and dementia is real, it's profound, and what's only now being looked at is the impact this is having on caregivers. So these are some, again, in that earlier article from last summer, this risk of burnout, which is already there. We're always worried. I'm always telling my patients' loved ones that if you don't take care of yourself, soon you may wind up having significant, not only emotional impact, but it's going to impact your physical health as well, which is why the program that Susan and her team lead is so vital. So there's a risk of burnout. There's fewer resources available, like day treatment programs and other social engagement activities in the community because of the pandemic. Non-emergent care is not as efficiently available. Caregivers are having to balance multiple roles. So we always talk about the sandwich generation who's got kids at home and parents they're caring for, but now the kids are at home on school for video, and that's making everything even more challenging. And there's also the impact of grief because of the tremendous loss that we've seen in people with dementia. And then, of course, there's the ongoing issue of stigma about aging, stigma about mental health and mental illness issues, and stigma about dementia itself. So what about in the long-term care population? So when I first started thinking about this topic last spring, a lot of the work was being done and a lot of the stories were being done about what's going on in long-term care. And I just wanted to highlight some of the issues that we've learned so far. One is that social distancing has amplified already what exists sometimes in long-term care, which is social isolation. And, you know, family members and other caregivers that would come into long-term care facilities help the long-term care staff in terms of providing a sense of cohesion between the staff and the patients and the residents. They understood them better. They connected with the family members supported one another. But without that visitation, there was this lack of cohesion that made caring for these individuals more challenging. The lack of the ability to communicate, knowing the people as well, sometimes having that family member there was an added source of support that was now missing. And there was this added level of worry and guilt leaving loved ones in long-term care facilities. And some have taken their loved ones out, of course, which then provides even more stress. Just as today, I was on the phone, on the Zoom, with a patient's daughter, a patient of mine who sadly went through COVID-19 for 9 months in an assisted living memory care unit without any infection until December. And then she developed COVID-19 and she passed away within 10 days of her illness. And her daughter, who was a loving caregiver who lived pretty close by the assisted living, did not see her mom for the entirety of the pandemic. And at the very end, she was invited in to say goodbye to her mom. And she was getting all sorts of pressure from her adult children and from her brother not to risk her own infection by visiting her mom who had an active infection. And so she didn't go in and she didn't see her mom, and her mom passed away. And today we spent time talking about her guilt, understandable guilt and second guessing. And there's just been a lot of that, a tremendous lot of that over the past year. So a couple of things I want to highlight as a psychiatrist that I think is important to mention. First is what happens to our brain when we're stressed. And all of this seems very obvious, of course, but when we're in the moment and we're experiencing these symptoms, it's very hard to take a step back and understand what's going on. But when we're under stress, we become impatient, we become reactive. Sometimes we act irrationally, and we become very focused on ourselves. We close ourselves down to suggestions and advice of other people. We also, I think, experience a world that is more sped up. We feel like everything is urgent. Everything needs to be done immediately or yesterday. And also we feel maybe that everything is against us. And this is a normal reaction to excessive and extreme stress. And unfortunately, it can lead to problematic symptoms and behaviors, as we'll talk about. Now, contrast that to when we're calm and our anxiety levels at bay. Our brains are more able to think and to problem solve, and we sleep and we eat better, and we relate to people better, both at work and at home and with our families and our friends. And we can reflect on situations and our responses so that we can find more effective and long-lasting solutions to everyday problems that may arise. And we just can't do that when we're under extreme stress. And yet we may not even realize the stress that we're experiencing. So none of the next few slides are unknown to you, but I do think it's worth highlighting the difference between stress and a condition which may require more medical or psychological intervention. So there's something called anxiety disorders, but these are the symptoms of anxiety. Now, when you have a number of these symptoms, it's one thing to have a symptom like startling easy or worrying a lot, but when that symptom affects your ability to relate to people, to function in your life and your job, to sleep, and to do well and experience a good quality of life, that's when it's a problem. That's when you really need to seek attention. The goal is to intervene early before it becomes a problem. But when it starts to accumulate these symptoms and it affects your quality of life and your day-to-day functioning, that's where medical attention is needed. Now, when you look at these symptoms of anxiety, keep them in mind because I'm about to show you symptoms of depression, and you'll notice there's a lot of overlap. So like you'll see poor concentration and poor sleep and excessive worry, negative thinking. Those are symptoms that overlap these two conditions. But inability to relax, restlessness, easily startling, fear or apprehension, my goodness, muscle tension. I have so much muscle tension headaches now. I never used to get these things, but it's from the stress and the overwhelming anxiety that I think a lot of us are under. The other condition I want to mention is trauma. We may not think about it this way, but the experience that many of us have lived through over the past year is one where we've experienced acute and now in some ways chronic trauma, whether it's because we've lost loved ones, we've witnessed the death of others, we felt guilt about not being there for the death of people. Those individuals who have been working on the front line in healthcare, no more so than in long-term care facilities, whether it's assisted living or nursing home, and having people dying all the time, have been experiencing trauma. Trauma events that lead to symptoms such as withdrawal from other people and social isolation, which makes everything worse, and lack of sleep, or this hyperarousal or hyperresponsiveness condition I was mentioning before with stress that can really become problematic. We could avoid people or situations that are actually helpful and supportive of getting better because of trauma. We may re-experience the traumatic event either by seeing it or hearing it or smelling it. And then the more concerning symptoms where we may see or hear things that aren't there, or we feel physically or emotionally numb, or we experience this unusual symptom of depersonalization where we feel like we're not even connected to our bodies, where we're looking at ourselves from outside of oneself or up from above. These are some of the symptoms of trauma and indicate that someone's been exposed to a very stressful event and probably needs more specialized medical and psychological attention. And then finally, depression. As I mentioned before, you'll see a lot of overlap with anxiety and with trauma here, but changes in sleep and appetite and energy level and poor concentration. Those are some of the physical symptoms of anxiety, of depression, but also there's a lot of emotional symptoms or cognitive symptoms of depression as well, like ruminating or worrying on negative things, on losses, on regrets, really like our brain works in a vicious cycle and we just can't get off that loop. Those are some of the most challenging symptoms of depression. Or we feel guilty or worthless or burdensome, or like we didn't do enough or we should have done more, even though we've been working so hard. And then what we also really worry about are recurrent thoughts of dying or wanting to be dead or even ending one's life. And I'll show you the slide in a minute, but suicide, thinking about suicide has gone up a lot in the pandemic, but especially in younger adult populations, which I'm going to highlight in a little bit, for a whole variety of reasons that we can speculate on. But thoughts of death and dying and risk of suicide is something we really have to pay attention to and clearly warrants urgent medical attention. So before I get into some of the caregiver specific things that we've been learning, I want to just mention about some really basic recommendations. Not that you don't know all of this stuff, but it's easy to forget this when we're overwhelmed and we're really busy and we're stressed. But we have to monitor our own stress and well-being. And the first thing in that regard is to name what's going on, to validate the emotions that you're feeling. Sometimes it's just a normal response to an abnormal situation. We have to eat and exercise, and the exercise doesn't have to be long distance running. It can be 15 to 20 minutes of walking a day, or doing mindfulness exercises or yoga. And eating well is key. When we're in a rush and we're stressed, we tend to eat foods that are not healthy for our heart or our brains for that matter. So we want to think about healthy eating, Mediterranean diet-like principles. We want to stay connected to friends, family, and colleagues. In a time of social disconnection, physical social disconnection, it's easy to become physically isolated. It doesn't mean that we have to be emotionally disconnected. And so whether it's Zoom or phone calls or outdoor gatherings, which was easier last summer and early fall, and will become so again in the next couple months, we hope, around here, staying connected is key. One thing I noticed early on in the pandemic, which got worse in June with all the riots related to racism, and then certainly with the election and the events of January 6th, we've been inundated with media events that are overwhelming and exhausting and make a situation in our lives, frankly, that much worse. So although it's important to stay up to date with what's going on, you got to remember and need to know how to get vaccinated, for example. But if you dwell on all of this or overwhelm yourselves with media, whether it's radio, TV, or social media, it can really be problematic from an emotional standpoint. It's also really important we watch our relationship with alcohol, drugs, and other maladaptive behaviors, irritability and lack of patience with our loved ones, for example. But as a way to cope, many people have taken up drinking or more drinking or using other drugs. And some of this, again, a glass of wine a day, red wine, maybe with no prior history of alcohol use is fine, but more persistent and regular use can be problematic. For those of you who are trying to care for a loved one and work, this has been overwhelming. I am on many Zoom calls a day, whether it's with patients or with colleagues. And I see animals, I see family members. I know that people's work lives and their personal lives have now been merging in ways that never happened before and frankly are not healthy. So we have to really be prepared for and plan the work we do and pace ourselves and take breaks when possible. And then remember that it's important, and especially when in the context of caregiving, it's so easy to forget about our sense of purpose and why are we doing the things that we do. and making sure that we honor the work that we're doing and in the context of caregiving or whatever it may be, and the importance of that, and try to find meaning in it. So let me talk a little bit about our memory care initiative, which we're doing here in our system, which I mentioned earlier. So we did a survey. We have an intervention group that has a team, like I mentioned before, that's in the practice working with patients and caregivers and their family members. But we also have a control group that are getting usual primary care without this specialized memory care team. But before we started the intervention, we did a survey of people with dementia and their caregivers to try to understand the impact of the pandemic, but also what issues caregivers face in their care of loved ones with dementia. So in the survey that we did, and this is sort of hot off the presses, not yet to be, we're going to send you a copy of all these slides, but I'm not going to send the next 3 or 4 because this data is really hot off the presses from my colleague, Karen Donnellan, and her team at the Mongan Institute and Brandeis University. And we want to make sure that it's complete before we, and publish it before we send it around. But if you look at this, the first column or the middle column is patients, 55 of them, and caregivers, 41 of them. And these are people with dementia and their caregivers. You can see that the caregivers are predominantly, sort of a mixed, but 54 and younger is a quarter of the population, a quarter between the ages of 55 and 64, a little bit between 64 and 75, and then 75 to 84. So fully a quarter of people who are caring for a loved one with dementia in our cohort here, which is not that big, are over the age of 75. And if you add the two together, 85 and above, it's like 1 out of every 3 is 75 and above. And this is a hard job for a 25-year-old. This is mostly a white population and a non-Hispanic population. And it's predominantly women, about more than 2 to 1. So that's the cohort that we screened here. The next few slides are busy, so I don't want you to dwell on the details. I want to make a few points. The first question we asked was how the coronavirus pandemic has changed your life, and is the caregiver's life, in each of the following ways. And red and yellow represent it's impacted you at least moderately or severely. So moderately was defined as a change in 2 or more areas, and severe is 3 or more areas. So if you add up like yellow and red together, the questions or the domains in which this was really impactful. So over 30%, there was tremendous stress and discord in the family. Over 60% felt stress related to the pandemic itself. There was a problem, about almost 40% had difficulty accessing family and social supports outside of the family. And then, of course, nearly everyone's routine was disrupted. Interestingly, access to medical care amongst this population, although disrupted in around 30%, wasn't as disruptive as some people may indicate. And then no change in mental health treatment access, either because people weren't accessing mental health care beforehand and didn't need it now, or because they have plenty of access. And so I'm pretty sure it's the former and not the latter. And then a couple of comments that people made that I just wanted to read. Then these may resonate with you or not, depending on your own particular situation. So one person said, we're doing everything ourselves. We have no contact with neighbors or friends who would come to visit. Everything's done by Zoom. Whereas on the other hand, some people said, well, life hasn't changed that much. She never would go out of the house much before the pandemic and has no local family, so the routine is the same. Some people commented on the lack of visitors. We have a big family and a grandson who's a nurse at MGH, and we don't see the family much, and we do, it's on the porch. Interestingly, when sports were canceled early on in the pandemic and the lack of sports on TV was an issue for some, before COVID, my parents were independent and they just needed reminders for taking medications or going to appointments. But now I'm doing everything for them. They're grocery shopping, picking up medications, taking them to appointments so they don't have to go in an Uber. And my mom has leukemia, so she's got a lot of medical appointments. It's been a lot. And she has kids at home who are my full-time job as well. Kids who are at home and also her full-time job, like we talked about already. And then one person whose mom was going to the local Y to exercise and going to church, and this is no longer there, and it's a big loss. And she's letting her go to church, but even making these decisions about where one can go winds up becoming guilt-ridden and anxiety-provoking. So this just gives you a flavor of some of what we were hearing from caregivers. And then in terms of strain, stress, burden, et cetera, again, the here in blue is yes regularly, and in gray is yes sometimes. So the big areas here was upsetting to see how the person they've cared for has changed so much from their former self. This is caregiver strain measured during the pandemic, but not necessarily related only to the pandemic, but rather the general experience of experiencing stress as a caregiver. So behavior is always rated highly in terms of what causes strain, and caregivers, I don't have to tell all of you that. Emotional adjustments to being a caregiver, changes in plans, someone's own plans get derailed because of what they have to deal with a parent or a loved one, adjustments to the family, feeling confined, and so forth. To understand this better, we actually wrote and just got a grant from the National Institute of Aging to do a systematic survey of 600 caregivers of people with dementia, both professional caregivers like nurses and nurses' aides in long-term care settings, and family caregivers and care partners. And we're going to be looking at the caregiver experience during the pandemic, how COVID-19 and the circumstances of the pandemic have impacted caregiver strain, and specific COVID-related factors on behavioral symptoms of dementia and the severity of dementia. So before I open it up to questions, I wanted to point out maybe a silver lining that we're learning from this pandemic in older adults. So this was data that the CDC published and released in August. And there were 4 groups studied in this survey based on age. The younger folks, the 18 to 24-year-olds, essentially college and right out of college, 25 to 54, people starting their families, 45 to 64, and then the baby boomers and beyond, or a little bit before and beyond. So the first baby boomer turned 65 10 years ago. So the last 2 groups include some baby boomers. So what you can see here is that if you look at the young group, the 18 to 24-year-olds, the prevalence of anxiety and depression in this population was 50% or higher. Trauma-related stress disorder, 46%. Substance use that was new or higher, 1/4. And 1/4 were thinking about killing themselves. Now, if you contrast that to the oldest demographic, the 65 and above here, look at the difference in those numbers. It's dramatic. Anxiety rates of only 6%, trauma-related disorders 9%, and suicidal ideation only 2%. Now, one of 2 things could be going on here. Older adults lie. That's possible, I guess, but I tend not to think so. I actually think this reflects something about the wisdom of aging, resilience with aging, having learned from previous life experience in aging. And I'll tell you that, and I've said this to others, so if I've said this to you before, I apologize. But in the first month of the pandemic, when my kids came home from college, my daughter, who was 19 at the time, and had just been sent home from her freshman year in college, was at the dinner table, and she realized at that moment that her freshman year had ended abruptly. And she started to cry, and I said, "What's the matter?" And she said, "Well, I wish I were your age." And I said, "Why do you wish you were my age?" She goes, "Because this is what your life is normally like." And I said, "What?" I thought we had more of a quarantine-like life than we were experiencing at the time. But she said, "My life is all about my friends and my colleagues and my peers and going out to parties and making relationships and traveling, and I can't do anything now." And she was devastated. And although she's coped very well, despite all of that, you know, I'm not surprised at these numbers based on what I heard from her and my son and all of their friends. But interestingly is this resilience factor. So if you look here, you know, what is resilience all about? So it's a dynamic capacity, can change over time and with different circumstances, but there are both internal factors and external resources that are brought to bear that enhance resilience or coping. It could be cognitive capacity, personality, and one's own physical health. It could also be external, like social status or financial stability. But there may be very interesting biological factors that influence the stress response. So everyone experiences the pandemic in different ways. I mean, we've all noticed this. If you take a step back and think about it, how some people, especially early on, were anxious and worried at other time, all the time. And others were like, I'm sort of somebody who doesn't mind being around myself all day long, and being around others stresses me out. So there may be social and biological factors that influence our response to stress. And that the net effect of these psychosocial and biological variables in the context of COVID-19 in older adults with resilience decreases the risk of worsening current conditions or developing new conditions. And there's a way in which resilience will counter this loneliness experience, like, in other words, the ability to be alone, but to still feel contented. And then finally, there's this trait of wisdom, which Erik Erikson talked about in The Final Stage of Life, where this complex personality trait, which is comprised of empathy and compassion, and also the ability to regulate our emotions and reflect on ourselves and our lives, and accepting diverse perspectives, and being better at social decision-making, and also incorporating spirituality into our life. All of this comprises the concept of wisdom. And having lived through previous life experiences has also contributed to the fact that older adults seem to be experiencing this protective effect in some ways because of resilience. When you get these slides, you will see that there are a lot of resources here locally, but you don't need to go into an office to see someone to seek mental health care. McLean, where I work, has put up on our website at this web link here a whole variety of resources for all age groups. Some are self-help and self-directed, and others are to seek actual treatment. Mass General's done an amazing job of putting together a number of resources as well. All of these websites, by the way, have constantly been updated since the very beginning of the pandemic. And then finally, in terms of trauma, the MGB put out this great behavioral health symposium series. You can watch these videos, if you will, at your leisure. They're available to the public for free. A couple centers, both locally and nationally. But Brigham and Women's Hospital put together this really well-written and concise trauma-informed care handbook that, again, there's a link here to this booklet that you really may want to take a look at. It really helps you understand what trauma is, response to trauma, resources to deal with trauma, and so forth. So in summary, and I think we have plenty of time for questions, many of you know about the 36-hour day, the Nancy Mason, Peter Rabin's book that's now been out. I think it's in its 6th edition or something like that. But caregiving during the pandemic has even exceeded what the 36-hour day stressors would make one imagine you could experience during a given day. It's important that we recognize as caregivers signs of escalating anxiety, of depression, of stress and trauma before they start to impact quality of life and functioning, because we want to head off and prevent some of these deleterious behaviors, maladaptive behaviors that can lead to excessive drinking, etc. We need to pay attention to our own needs. This is so hard as caregivers. We're constantly focused on those around us. But what about our sleep? What about our diet? What about exercise? What about setting time aside for enjoyable activities? More than usual, we have to be proactive in asking for help. Most people that I know who are caregivers are not good at asking for help. We have to ask for help. People will be there to help us. We have to maintain social relationships. And despite the physical distancing of COVID-19, it is possible to remain emotionally connected. And then finally, when symptoms of anxiety, depression, and grief are impacting quality of life and daily functioning, it's really important to seek professional help. Talk to your primary care physician. Tell them what you're experiencing. Really important that you just don't keep it inside, because it will likely get worse before it gets better. So I'm going to stop there and stop sharing my screen. And I'll turn it back to you, Susan, or however you want to organize kind of questions, and we'll go from there. And I think you're on mute.
have a lot of things going on my screen. So can you hear me now?
Yep.
Okay, good. Got all kinds of interesting things going on. Thank you, Dr. Forster, so much for just bringing this conversation up. I think is so important for us to sort of settle in and really give space for this conversation, and really thinking about how hard this is for all of us who are living with this disease. And I've gotten some really interesting questions. The first couple of questions, though, have really focused on what you identified as the difficult decisions to make. This particular person talked about her mother, who's 97, and she's housebound. Every other week, she's continued to take her to her hairdresser, which, when she goes there, she describes that she's, responsive and more bright and interactive. She also says that the guy who cuts her hair is also 85 years old. So I want to be there already. I could just imagine that is a hoop, but that the hair salon is taking all the precautionary steps that they could take to make it a safe environment. And there's obviously these wonderful reasons, for her mother, that she can see the impact of it, but it's still a difficult decision. Her question is she doing the right thing? So I wonder how you might speak to that.
So it's a great question. And I think it's one that's come up almost every day when I've talked with caregivers for patients with dementia, and even in my own family, frankly, this has come up. And I think there are a number of factors to weigh. First of all, there's no right or wrong answer. It's really important that the stress of isolation and loneliness can be as lethal as the stress or the risk of getting COVID-19. So I think it's important to remember that it's, you weigh the pros and the cons of potentially, like you're doing, bringing your mom out to, not only does she like the fact that her hair looks good, but she's also engaging with someone in the hairdresser, him or herself. So I think number one, there's no right or wrong answer. Number two, you need to have a risk-benefit discussion with your mom, like you would about anything. Is this a risk you can tolerate? And I've had patients who have continued to go out to restaurants with precautions. They've gone to the hairdresser when it opened back up. And I have others who won't even go to the grocery store still. And I know many who are now getting vaccinated who are still not changing their behavior in any way, which is probably a good thing for now. But I do think that the tolerance of risk varies hugely from person to person based on lots of different factors. So just keep that in mind. And so don't feel guilty, but be cautious. Make sure that there's some mechanism in the hairdresser to screen for COVID-19 infection in their employees on a regular basis. Make sure that they're wearing masks, probably now double masks. They should be wearing, and you should be wearing, your mom, a face shield as well as a double mask. I mean, all of these things I think will help. And then if we have time, I can tell you about my own horrific hairdressing story that I experienced a few weeks ago. Okay, we should go on. And then at some point we'll get to the other chat that I can see, because there's a lot of good questions in here too.
Yeah, I just wanted to follow up on the words that you use, tolerance for risk, and how do you measure that? And I think that's a conversation I've had with families for years about all kinds of decisions that you have to make. And so it's also, the other side of it is, what's the risk of not doing it, right? You have to think about that, of not having that opportunity for stimulation and social engagement, and probably the love and joy that you get from going out and being socially engaged in that way. And I appreciate that you also mentioned, it just makes you feel good about yourself when you go and have a good experience at the hairdresser, which I haven't had in many, many months. I can't wait to try it myself. But that tolerance for risk, I think, is an important conversation to have with the person you're caring for, if you can, with a trusted, person, if you're making decisions on behalf of the person you're caring for. So, what other questions are you seeing here? Recruitment for studies is one.
So there are a couple here. So let me just go from there's so many good questions here. Okay. Yeah. Tiffany had a question. Could you explain how patients and caregivers were recruited into our study, and plans for diverse and inclusive recruitment, which is a great point, which is actually something we've been talking a lot about. And the comment that Tiffany makes is, I know that dementias are heavily underreported amongst underrepresented minorities, which is extremely true. And we saw that data on the racial disparities in terms of mortality risk with COVID-19 amongst the Black dementia population. This is a huge challenge. I know that, I mean, you all at MGH, we all across our healthcare system, and frankly, the Alzheimer's Association's done a great job of trying to reach some of these underserved communities with regards to health overall, but dementia in particular. For example, our system now is an entire United Against Racism campaign to try to reduce some of these disparities in healthcare and improve healthcare equity. But what we're trying to do, and what we're going to be doing in the next iteration of this, is we're going to go out and recruit from primary care practices that serve these communities. So in our next iteration of this study, as I was briefly mentioning, 1/3 of the sample is going to come from Baltimore, in inner city Baltimore, largely African-American population affiliated with practices affiliated with Johns Hopkins. And the third site is going to be in Miami, where we have a huge, mostly Cuban, but certainly Latino population that we're going to be recruiting from as well. So we can have a much greater diversity of experience and need, which is definitely important. Another question was recommendations to families who are resistant because of COVID-19 to have someone come into their home, which is vital to care for a person with dementia. This is from Tammy. Thank you, Tammy. This is a great question and a challenging one. Sadly, I think we've all heard stories where the route of entry of this virus into a home or into long-term care was from the caregiver. And so this is a real problem. This is not like something to say, oh, it'll be fine. Early on in the pandemic, it became pretty apparent that a lot of nurses' aides in long-term care facilities work in multiple facilities. They were taking the virus from one nursing home to another nursing home, from one nursing home to our inpatient unit. That's how we got our first outbreak last spring. So this is hugely problematic. And I have a friend who runs a home care agency, and they've had the same problem. One of my colleagues' mothers died from COVID because the caregiver gave her COVID. So I think the best thing that can be done is to make sure you know the COVID status of the caregiver. Hopefully our state will start to vaccinate at a more brisk pace in the next few weeks, and there'll be more vaccinated caregivers and vaccinated people who are older than 75 and with these chronic comorbid conditions. So the overall risk and the overall prevalence of infection will go down. My guess is over the next 6 months, this will become much less of an issue, but it won't go away completely. So I think, again, knowing who these folks are and what type of COVID-19 testing that they're having and making sure they're doing all the basic principles is probably the best you can do. And at the end of the day, it gets back to this risk tolerance. Mm-hmm. If there's a safety issue with regards to caregiving and you can't lift mom or dad out of the bed or the bathtub, and you've got your own medical issues, then you need a caregiver there. It's just the bottom line. And that's a pure safety problem, which may be way higher than any risk of transmission. So anyway, that's the way I would think about it. Susan, you want to comment anything else?
Well, I think I add into the risk factors there, just the level of exhaustion from being a 24/7 caregiver. I've certainly families that I've worked with, one in particular that I'm thinking of, that were, had really gone to every extreme to not have any outside contact and wiping everything down for so many months that they were, the caregiver had become sick at some point. And so really it continues to be that tolerance of risk question. And at some point, it absolutely, for everyone's well-being, it's worth the risk, I think, to have someone in, but it's taking all the precautions that you can. And I absolutely agree that, wanting to know the status and seeing if people can be, if you're hiring from an agency, especially, what precautions is the agency providing? Are they providing the PPEs for people when they come in? So doing everything you can to think through, but then there's only so much you can do. And at some point, it's important to take the risk, I think, sometimes.
So one earlier question, this will be pretty quick. Somebody asked to explain the concepts of hyperarousal and hyperresponsiveness more. I mentioned these symptoms in the context of trauma-related symptoms, but essentially, if you imagine a startle response where you hear a noise, a benign noise, or you hear, or there's a lot of commotion or something, but whatever the trigger may be, that somebody's level of responsiveness is just quick to react with a lot of, sort of outpouring of stress hormones and high level of anxiety. There was a question about, do you see seizure activity in later stage dementia? So seizures are, people with Alzheimer's disease are at a higher risk of developing seizures at all stages of dementia, and certainly as the disease progresses. There's a lot of factors likely associated with this, none of which we understand terribly well, but the structural changes occurring in the brain, the deposition of these plaques and tangles. Some people with dementia develop these small mini strokes, but all of these structural changes in the brain could potentially trigger seizure activity. And then very importantly, and this is true for anybody with a history of seizures, sleep deprivation and stress can provoke seizure activity, dehydration, electrolyte disturbances, things like that. So there are changes in the brain, but also other medical factors, and then the psychosocial stressor factors that can also bring this on. Certainly someone made the excellent point that for clinical trials, they provide free transportation, which helps to improve diversity of recruitment into studies. I couldn't agree more. And now, of course, some of our studies are taking place remotely, where we're collecting a lot of our data through Zoom and phone.
One of the questions earlier was just about if the family is, if the caregiver has already had COVID, are they resistant? Is that a protective measure so that they feel more confident being the caregiver and not transmitting the disease?
So we know that if you've had COVID-19 yourself, you develop an immune response, and future exposure to the virus should prevent you from re-experiencing symptoms. It doesn't mean you couldn't become a carrier of COVID again, potentially, but perhaps less likely to transmit the virus, and certainly less likely to get sick. What we don't know is how long that lasts. We don't know if everyone develops this immune response and how long the immune response lasts. The same question is true, though, for people who have been vaccinated. Now that we are having increasing numbers in our state who are vaccinated, if you've been vaccinated, are you in the clear? Are you not going to get COVID? And most importantly, are you not going to transmit it to someone else? So I think even just today, the study that came out of Israel has, with a Pfizer vaccine, has shown that it seems to reduce infection or serious infection by like 94%. I mean, it's just like the clinical trial. So like took clinical trial data, put it in the real world, similar findings, which is great. That means that if you've had the vaccine, your risk of getting a really sick, being really sick or hospitalized or dying is very, very small now. That's amazing. But we still don't know, number one, how long it lasts. We also still don't know, although we think it seems to be the case, that we don't know for sure, can you still be an asymptomatic carrier of the virus and still infect other people who haven't been vaccinated? So for those unknown reasons, even after being vaccinated and even after having COVID-19, don't change your behavior. Continue to wear masks, continue to social distance, continue to hand wash. And if you do all of that, then I think you're going to be good. Yeah.
I wanted to make sure we stress that even after the vaccination, to continue wearing masks until we know more about it. Another detail that someone asked for clarification is, how do you make sure that a caregiver coming in has been tested? How do you confirm the COVID status?
Well, you could do everything from call the agency itself, find out exactly what their testing policy is, find out about the test results for the person coming in. The problem here becomes when someone gets a test, it's private health information. And so would an agency tell you that, Mary had a test yesterday? Probably not, but you could at least find out their policy. You could ask the person coming in. I guess you could potentially ask them to show you proof that they had a negative test, but I think that's all you can do is ask what the policy is. And then maybe ask the person if they're willing to share their results with you. I mean, that's probably the best that you can do. I don't know. I'd be curious what other people would say about this. It's tricky, you know, we don't know what we don't know. It's like this invisible illness that's mysterious and scary and so widespread that, here's the other way to look at it. Assume everyone is carrying the virus. You wouldn't behave any differently if you knew they were negative anyway. You would still wear a mask or a double mask. You'd still potentially wear a face shield if you were coming in close contact, and you would still socially distance as much as possible. So you would not really change your behavior, even if you knew they had a negative test, because they could have had a negative test 3 days ago and then on the bus ride over got exposed to somebody with COVID. I mean, who, you know, there's so many unknowns. But again, remember, sometimes, and maybe more often than not, it's better to have that caregiver in the house helping out, caring for mom, dad, or spouse, because it really is the risk benefit ratio is way favored towards having home care.
Yeah. Well, I think to take the conversation the next step, those are the questions that we have now. Please, if anybody even wants to share their own experience, please do so. I want to take this opportunity to point out that just building this community that we have to share information with each other, to share support with each other, to share, our best knowledge and wisdom that we have with each other about this is so important. And I think that finding ways to stay with community, whether that's joining online programs like Dr. Forster provided in his slides, the programs at MGH through the Dementia Care Collaborative, where we are really just trying to stay connected to each other as much as possible, to share our grief and our wisdom and our answer each other's questions and provide all the emotional support that we can to each other. It's just it's needed forever and ever, as the many years that I've been in this field, but we really have to make that effort at this point in our world today. There's someone here that's just really looking for some guidance for their father in dealing with episodes of anxiety and agitation, which I think are, we're at higher risk for now, given our isolation and lack of activities.
So anxiety and agitation are really common in non-pandemic times in people with dementia. Probably over the course of one's illness with dementia, the rates of any psychiatric symptom, whether it's depression, anxiety, agitation, paranoia, it's nearly universal. There's some degree of this in pretty much everyone. It becomes a problem, of course, when it's severe and it's impacting quality of life, and then very importantly, when it's impacting safety. And so the first thing to do is to figure out why. I mean, there are all sorts of things to do to control agitation if you know why the person's agitated. And also, when we say agitation, it's important to define, well, what do we mean by agitation? Is it like yelling occasionally? Is it throwing things across the room? Is it behavioral disruption agitation that's physical? Is it verbal? How severe is it? When does it occur? And so forth. So the first thing is like describing it. The second thing is what's driving it. And when I think about like what causes agitation and dementia, there are three main buckets of things that cause agitation. The first bucket are medical problems, like maybe this is a UTI, or maybe it's the first sign of COVID-19, which is unfortunately not that uncommon during this pandemic. We've seen many people who don't have fever, chills, cough, but they have confusion and agitation, and they have a positive COVID status, or they develop one in the next 48 hours. I've seen way too many of those situations. So it may be that there's a medical problem, constipation, pain, medicine side effect, too much alcohol. All of these medical issues can trigger agitation, not to mention the fact that the brain is changing and we're experiencing loss of neurons in the centers of the brain that control behavior. And so we're becoming disinhibited. We're less likely to control our emotions or our behavior. So all of this are in the medical bucket of causes. The second big bucket are what's going on around the person. Is it sundowning? Is it because the day's getting later and darkness is descending? Is it because the person's tired from a long day? Or maybe it's happening first thing when they wake up and they don't know where they are and they get very upset and anxious because of lack of recognition of their surroundings. Or maybe they are unable to recognize their loved one and they think their loved one is someone else, and they get confused and very concerned and combative because they think a stranger is in their home. Or maybe they're in a long-term care setting and it's the afternoon and there's a change of shift and there's just an incredible amount of commotion and people coming and going. And so there are unbelievable number of environmental causes and triggers to agitation. The third big bucket are psychiatric causes. So maybe your dad is somebody who had depression earlier in life. And actually agitation and anxiety now is actually not dementia related only. It's because it's recurrent depression. The reason I tell you all this is because this is the way a clinician thinks. Like, if I'm going to do something about your dad's agitation, I don't want to throw a pill at it without understanding why they're agitated in the first place, because the treatment could be an antibiotic if it's a UTI. It could be the way in which you're communicating with your dad or the way in which the aide is responding to your dad's needs. And it could be because they're seeing people outside the window and they're scared to death. So until we understand the cause of the agitation, it's hard to come up with a thoughtful behavioral and or medication approach to treating it. Once all that is done, then there's a bunch of different treatment pathways one can go on. And this is where I think professional guidance is critical, because your job is not to be your dad's primary care doctor or psychiatrist or neurologist. Your job is to be his daughter and potentially his caregiver. And so getting him the help he needs to figure this out is really critical. So that's not a great answer. Like, it didn't say like one obvious thing to do, but if you have that approach in mind, that usually will address the issue. And at the end of the day, I bet every single one of you on this Zoom call would agree that when you're thinking about goals of care for a loved one with dementia, it's really balancing both quality of life and safety. I mean, there may be other smaller things, but those are the two big things. And if you keep that in mind, then that you'll find a treatment approach that will help balance both safety and quality of life.
I just want to say that I think, all the points you just illustrated make me mindful of how important it is to get education and support as a caregiver, right? So that you have a person at your primary care practice or neurologist's office or psychiatrist's office to call if you're seeing a change in someone's behavior or increasing agitation and anxiety that you're unable to redirect, or you just find yourself without options or not knowing how to handle the situation, that it's really helpful to talk through sort of all of the options and possibilities to try to come to arrive at a plan. And often it takes several tries, right? It can take many steps to resolve these kinds of things. So I think the important message is you're not alone. I think if you're attending this tonight, the message, really the biggest take home message, is that you're not alone, and that we invite you to be in contact with us and with your providers to keep the conversation going, because this is not easy. This is such a difficult disease to manage. And I'm just happy that you're all here and that you know that you're not alone in doing this. So thank you for that really great explanation, Dr. Forster, because I think it is not an easy answer to what causes anxiety and agitation, that it needs to be a conversation with a provider.
I'll just, Susan, somebody sent me a private message, which I'm happy to comment on unless other people.
Sure.
One of the research areas that we've been investigating is with, for people with agitation and aggression that's really severe, that's not gotten better with medication and other interventions that we've been talking about. And we've gone through that evaluation that I just mentioned. A number of years ago, we started to treat people at McLean who were like this, where nothing was working. And there was really limited option, but really sedating people, which no one wants to do. And so we experimented with electroconvulsive therapy, or ECT, which is a well-established treatment for depression, but had been very really in its infancy and anyone looking at it for aggression and Alzheimer's disease. And it turns out that it was quite helpful, remarkably helpful, actually. And some people stayed on maintenance treatments where they would come back to get treated, every month for years. So we eventually got a large grant from the National Institute of Aging, and we're just launching right now a multi-center 5-site study with 200 people not with mild agitation, but severe agitation and aggression in the setting of Alzheimer's disease, where people's cognitive impairment is quite poor to begin with. And our goal is to see if it's both effective in reducing these symptoms and also safe. And we created a control group. So it'll be years before we have an answer, but I'm really thrilled that we're moving forward with this work. And again, it's for a subset of people, not with the majority of people of severe agitation.
Mhm. I just wanted to mention, I know there's so many familiar faces and names out there, and I just heard from an old dear friend who I knew from my work at the Alzheimer's Association years ago, who said, do not forget to mention the 24-hour helpline at the Alzheimer's Association is a great resource for caregivers. If you don't have a particular person, or if you need someone at 1 o'clock in the morning, they are a great resource to talk about the symptoms and how to manage and to make a plan. And that number I put in the chat, I know this from all my years. I knew it immediately. 800-272-3900. Thank you,
Can I
Sherry.
second that, Susan, and just
Yeah.
say that Susan knows this because of my work and volunteer work and serving on the board and all this for the Alzheimer's Association, but they're the single, in my mind, best community resource available for you all. They're always available, the 24/7 hotline. They have the Dementia Care Consultation Service, which is amazing. Fundraising allows them to support it for the most part. And it's really, in some ways, when you're looking for guidance or direction, it's a great entry into the system and into the world of, what do I do now as a caregiver? That's how I first met you, Susan.
Yes.
Was in the context of the work that you did for them. And frankly, someone who called the 24/7 hotline wound up luckily meeting you over and over and over again, right?
Mhm.
So I agree.
Yeah, and I just have to say that Dr. Forst and I were talking about this years and years ago, that taking all the things that we learned at the Alzheimer's Association and trying to make this information and guidance and support for families also available from your doctor's office, because I think that's where people go first. And that's the piece we're working on, to make sure that doctors are also prepared and that there's an interdisciplinary team that includes a nurse practitioner or a social worker that can help with all of these issues related to caregiving and dementia. And the Alzheimer's Association is always there too. I mean, they are the go-to for counseling 24/7. Can't agree more. So those are the questions that we have right now. If anybody else wants to share, we have time for probably one more question or a comment, or if anyone wants to put anything else. I will just add, there is a question. Go ahead and answer this question. Can you talk a little bit about hallucinations related to dementia? It's a great question.
So just to define hallucinations. So hallucinations can be visual, where you see things that aren't there, things, people, objects, etc. You can hear things, voices that aren't there. You can have unusual tastes or smells. Or even unusual body sensations. So all of those are 5 different kinds of hallucinations. People with dementia experience hallucinations at varying rates. There's certain types of dementias that are more likely to, have this than others. So for example, some of you have heard about the Lewy Body type of dementia, which is characterized by Parkinsonian motor symptoms like tremor and rigidity and shuffling gait, but also pretty pronounced formed visual hallucinations where people may see babies in a room on a couch or animals outside the house, but very descriptive words are used to describe these visual hallucinations. And then some people with Parkinson's dementia develop these symptoms as part of the illness itself, but also sometimes as side effects to the medicines we give people with Parkinson's disease. So having a hallucination in the setting of dementia doesn't mean it's due to the disease in the brain only. It could be a medicine side effect, or it could be in the setting of an infection or another medical problem. So like with agitation, the first thing is, why are they having the hallucinations? And the second thing is to come up with a treatment plan to try to reduce them, because some people have hallucinations. It's matter of fact, oh yeah, look at those people sitting in my room. Isn't that interesting? And then they move on and they're not even bothered by it.
Right.
So why give somebody like that an antipsychotic medicine that's going to make them stiff, rigid, and fall potentially, or have an increased risk of stroke? Other people are frightened to death and they act on it and they become aggressive and try to fight the hallucinations. And so it really depends on the severity and the nature and the experience of it that also informs treatment.
And I think hallucinations are confusing too, because sometimes it can be a misperception. It can be a visual
Right.
perceptual
Very good point.
thing.
some people with visual impairment will imagine that they're seeing a pen, but it looks like a snake. Or, they see a glass, but it looks like, an animal or something frightening to them. So it may not be out of the blue in the air. It could be an illusion is what you're describing, Susan, where you
Mhm.
see something that's there, but you believe it's something else because of a visual problem.
So the first thing to do is to not argue or try to correct
Don't
or
argue.
convince. Never argue.
Never argue.
It's so easy to never disagree, to always stay positive. Um, let's see here. And I think the issue of, I say that so lightly, but it's not, I don't mean it. It's a very serious issue of how to respond when someone is in crisis, when someone is seeing something that isn't there, or not recognizing their surroundings, or they're just agitated and anxious and you're not sure why. How do you respond? And it's something that the Alzheimer's Association and the programs that we're here doing here at MGH, we're really interested in helping caregivers understand communication strategies, really how to make sure you don't make things, try not to trigger anxiety and agitation, and how to de-escalate situations, and how to manage some of those challenging symptoms that we see. So we have, again, you'll see on our website, which was put here in the chat earlier, the Dementia Care Collaborative.org. We have education programs that specifically speak to these skills that are really helpful for caregivers to have.